All right, you have a male patient being prepared for PERP and he's non-aortic stenosis and on thiazide as well. What's the pathophysiology of aortic stenosis?
So the pathophysiology of aortic stenosis can be split into left ventricular hypertrophy, increase afterload, and then decrease in preload. So we have left ventricular hypertrophy. This is due to expansion of the left ventricle. Then we have increase in afterload. This is because there's increase in pulmonary resistance of the left ventricle. And then we have decrease in preload, and this is secondary to increase in pulmonary pressure, which can then shift from left ventricular heart failure, causing heart failure, to right-hand-sided heart failure.
That's really good. Clinical picture for aortic stenosis?
The clinical picture for aortic stenosis is typically asymptomatic. However, you can get syncope, angina, and dyspnea. Other things that happen are you can also get an ejection systolic murmur, and also can cause arrhythmia as well, and right-hand-sided heart failure and left-hand-sided heart failure.
That's right. You'll be presented by an ECG, and you'll be asked to go through the ECG. So what do you think is going on in this one?
So here we have a positive deflection in AVR and a negative deflection at AVL. This is consistent with left axis deviation. We also have evidence of P mitrale as well, and that's seen in the leads V6 and V5. And you have a negative deflection in V3, suggestive of left ventricular hypertrophy.
And how would you calculate the heart rate based on this ECG?
So here I would divide 300 by the RR interval.
Can you do that, please?
Yes. So the heart rate here would be, so if I take the middle, so it'd be 300 divided by the amount of squares between each RR interval, which is approximately 5. So the heart rate here would be around 60.
And why did you decide to use this equation specifically?
This is because it's a quick, systematic method. And also it's very easy typically to do with a rhythm strip. Another way to do it would be to calculate the number of RR intervals in 30 large squares, which is equivalent to 6 seconds, and time this by 10. However, this is quite a long method of doing it.
Is the only difference about being long and short, or a quick method, or are there any other difference?
That's all I know at this point in time.
What are the complications of aortic stenosis?
So aortic stenosis is typically an outflow obstruction. So the complications that arise from that include left ventricular hypertrophy. You can get left-hand-sided heart failure. You can get a ventricular tachycardia, ventricular fibrillation. You can get and subsequently an MI. And then also other things include aortic dissection as well.
What investigations will you do for this patient?
So given the fact that this is an ejection systolic murmur, I would like to do a 2D echo. And this would allow me to assess the ventricular filling and see if there was a filling defect as well. It also allowed me to assess the patency of the valve to see if it was either congenital cause or due to calcification. And also I'd like to do some baseline bloods for this patient as well, including a full blood count, using these LFTs and CRP to see if the cause of the aortic stenosis could be post-inflammatory, such as rheumatic disease.
This patient is on thiazide diuretics. What's the relevant clinical problems that could be related to surgery?
So the predominant clinical problem for surgery is that thiazide diuretics would cause a hypovolemic picture, which would decrease the preload of the patient according to Frank Starling's relationship, and therefore cardiac output would be reduced. This is important in aortic stenosis as patients already have a reduced preload, and this might make things intraoperatively difficult as the blood pressure would be significantly reduced as a patient wouldn't able to maintain their ejection fraction.
So in terms of, so now you know that this patient is aortic stenosis and they're currently on thiazide as well. Are you going to proceed for surgery today, or what will be your plan?
So my plan for this patient would be to stop the thiazides on the day or morning of surgery, and then we can still proceed with this patient going to theatre.
What about aortic stenosis?
Given the fact that the patient has aortic stenosis, it would depend upon the severity of the aortic stenosis and whether the patient was symptomatic or not. We need to arrange potentially an echo. However, it depends on the urgency of the procedure, whether or not it's an elective procedure or it's an emergency procedure. An anaesthetic review would be essential here, and also a cardiology review.
Okay.
I would need to discuss this with my senior colleagues and consultant on call.
So this patient has bladder cancer in addition to the valve disease. Which operation will you do first, the valve surgery or the cancer surgery?
So there are advantages to both surgeries. If we do the bladder surgery first, the patient potentially might have debulking surgery of the bladder and then can proceed to reduce the recurrence of bladder cancer. However, the risk is that they may experience a syncope intraoperatively and have intraoperative arrhythmias. If the patient has the valve surgery first, there might be progression of the bladder cancer. However, if they might improve their symptoms in terms of their syncope and also reduce further damage for future heart failure. So here I would consider having a MDT discussion with the urologists, the cardiothoracic surgeons or cardiology, and this patient can then be decided based upon clinical priority, which is the first procedure they would like to do first.
And what do you think?
In this instance, my personal opinion, I would proceed with the bladder cancer surgery first. This is because the patient has bladder cancer. I don't know the stage and grade of bladder cancer, and I would like to know this information. But given the fact there is potential for bladder cancer spread, I think I would proceed with the bladder cancer surgery and have cardiac input intraoperatively as well. There is a risk of this patient dying on the table, and I would make the patient aware of the risks and benefits of the procedure. And I would also want to assess their capacity, and this would be explained in the consent for the procedure.
What are the prophylaxis used against infective endocarditis, and when would you decide using prophylaxis?
So antibiotics are typically the prophylaxis for infective endocarditis. However, they're not normally routinely given. This depends upon if the patient has had either clinical need during surgery or if they've had any previous dental surgery. And it depends on the clinical manifestation of the patient, whether or not they're pyrexial or not.
The patient received thiazides. What are the common side effects of thiazide?
So the common effects of thiazides are hypovolemia, hyperkalemia, hypocalcemia, and hypomagnesium. Yep.
And I think you pretty much mentioned this, but what are the thiazide used for?
So thiazides are used for heart failure. They typically act upon the distal convoluted tubule and prevent the reabsorption of sodium and therefore water through osmolarity. But their mainstay in treatment is for heart failure.
Fine. All right, let's go back. I think there are a few points to discuss here. The pathophysiology, you've mentioned it very well. As we agreed last time, you would need to go through the highlights or the titles of your answer first, and then you go through the specifics or the details of that. You've explained it very well, and I have no problem with the pathophysiology of aortic stenosis. The clinical picture, I think you've answered pretty much. You've given a good answer, but I think there is an area of improvement here. So I think go through the SAD, which is quite common mnemonic to be used, which is the syncope, vaginal pain, and dyspnea. All right. So I would go through this because this is typically a triad that happens in aortic stenosis. Orthopnea and paroxysmal nocturnal dyspnea can happen as well. And you can have some signs. This is pulsus, all trans, narrow pulse pressure, and the paradoxical splitting. So always classify, when I ask you clinical picture, we'll go through signs and symptoms. So always try to classify it into symptoms and signs. That's the only comment here. With the ECG reading, again, you've went through, so classically, you just go through the classic way of reading an ECG as a medical student. So you will go through the rate, the rhythm, and also the axis deviation, as you mentioned, and the ventricular hypertrophy. All right. So I think the way you explained the ventricular hypertrophy wasn't particularly accurate. So you want to mention that if the sum of the S wave in V1 and the R wave on V6 are more than 35 small squares, that's a ventricular hypertrophy, right? Okay. So if you calculate this here, it will be more than 35 small squares, and therefore that will be ventricular hypertrophy. So you want to mention the specifics. You've mentioned left axis deviation quite well, so that wasn't a problem. And also you can talk about the QRS complex, the T wave, and the ST segments, just to go through the classic way, very boringly, the way we did in medical school. All right. How to calculate the heart rate. The method is correct, but what I was looking for, the method that you used, is because this is a regular rhythm, using the quick method. All right. Okay. But the other method, yes, it can be used in the regular rhythm as well, but it's preferred in the irregular rhythm. All right. So this is the word that I was looking for. Right? So you will say, well, the fact that this is a regular rhythm, so I can use the short method, which is 300 over the number of the largest squares between the two RR intervals. And therefore, looking at this one, the heart rate will be estimated at 150. all right? Because you have, well, 2.5 squares or 2 squares, 2 larger squares. So it's pretty much 150 or 140 to 150. The complication of aortic stenosis, I think, again, you've mentioned some of them, but I would personally advise going through in a sequential manner, all right? So we'll start by, you have aortic stenosis, and therefore you have a left ventricular strain, left ventricular hypertrophy, left ventricular failure, and this, given that you would have left ventricular hypertrophy and failure, the preload will be decreased, and therefore you can have mitral regurg and atrial fibrillation because the left atrium will be dilated as well. And then you can have regurg all the way up to the lung. You can lead to pulmonary edema and pulmonary hypertension. And later on complication, you can get myocardial infarction, arrhythmia, and you can end up on the right side of heart failure, and you can end in sudden death as well. So I prefer the sequential manner. It's easy to remember if you're going through the same pathology, all right? It will make sense.
Sorry, I was going to say, I think you said the same in pathology to say, aortic stenosis and an outflow obstruction, and then go through left-hand side.
Correct. I think it makes more sense, and it will be easy to follow in the exam. So I will be able to know what you're thinking when you try and say this to me. What investigation will you do? So one of the good techniques in answering any question, and then I really prefer this, is to try to acknowledge the main issues before you start answering questions. For example, if you have in one of the trauma patients, or the burn, which we're going to do today. So if I'm going to ask you, how are you going to manage this? So you're going to say, well, I'm quite concerned about this patient. They have been in a major accident that included burn of more than 50% of their body. So I would necessarily manage them according to the ATLS protocol. And then you go through your answer. So you're acknowledging the actual problem that are going on. So in this patient, I'm asking you, what investigations will you do? So you need to acknowledge the stem. So you need to go back to the stem and say, well, so I'm quite concerned about this patient. They're going through bladder resection, potentially for a cancer if it's mentioned, and they do have aortic stenosis, and they're currently on thiazide, so I'm quite concerned about them. I'll do some labs, and that will include the basic bloods, specifically using A's, because I'm worried about that they are in thiazide. So instead of just saying that you're going to do basic bloods, this is a very generic answer that can be answered in any question. But if you say I'm specifically worried about their sodium and potassium and calcium and magnesium in this case, that makes sense because the patient is on thiazide. The other issue that I'm worried about is aortic stenosis. I don't know how severe that is, so I would like to look if the patient had an ECG, any previous echo, and I would request a new echo for them, a new 2D echo. And I will potentially get a cardiology review as well. So these are the specific investigations that I would like to mention. You can literally add anything you want, but if you acknowledge the main issue that you have here and then give a specific answer rather than giving a generic answer. All right, the patient is currently on thiazide. What is the clinical problems related to surgery? I think what you need to mention here, you mentioned dehydration, which is good, and decreasing the preload. You went more into pathology or pathogenesis, which I think the question is not asking. The question is mainly asking about basically the hypotension and the hypokalemia and the hyponatremia. All right. So you want to specifically mention those. I would look into the potassium, I would look into the sodium, and I would also look into dehydration. I'll try to correct this before the operation, and this can happen by stopping the thiazide on the morning of the surgery. All right. You've given a good answer, but I think you didn't manage to cover the main or the buzzwords that needs to be mentioned here. How to proceed? I think you're coming from a valid point, but I think I would disagree with that. All right. So first of all, this patient has aortic stenosis and they're currently on thiazide, and they need a proper preoperative assessment, and that includes an echo and doing all the needed bloods. All right. You need to speak with the consultant and get an MDT approach in this case. And again, the method of trying to acknowledge the main issues before giving an answer is very good. You will say, I'm very worried about this patient. They're currently in aortic stenosis. We don't know if they have a recent echo or not. We don't know how severe is that. So there is a very high risk that they might die in table if we don't have the information. They're also on thiazide. Would like to check their sodium, because if they have significant hyponatremia and they're giving more fluid, this might be exacerbated during the surgery. Therefore, I think it's reasonable to cancel the operation, and we can go through a multidisciplinary team approach, and that will be through discussion with my consultant, the anesthetic team, also the urology team, given that they are involved in the surgery as well. I would probably cancel the surgery, or I would cancel the surgery rather than saying probably. I would cancel the operation. I'll speak with the patient and speak with the whole team to get a discussion before the next operation and arrange investigations. So, like I said, you're coming from a valid point, but your point, I think you might end up killing the patient if they have ejection fraction less than 40. You might end up in a situation that is very difficult to manage. So I would definitely cancel the operation. Cancer, yes, it might spread, but it doesn't happen in a day or two. You can literally get all, I mean, in a good place, you can get all the investigations done in 2 days maximum, right? You can get the echo, you can get all the bloods, etc., and then you can make a decision about your operation. So in terms of what operation you will go with first, I would consider that will depend on the severity of the aortic stenosis. If the patient has severe aortic stenosis less than 1 centimeter, squared centimeter, with a ejection fraction less than 40 as well, I would consider doing the aortic stenosis first, because this is much more important and it has a higher risk of actually killing the patient. All right. So I would go with the aortic stenosis first, and I think this is the correct answer. The cancer, I think it can wait until the patient has the operation that might end up killing them. So I didn't ask you this question, but if the bladder cancer is cancelled, because you pretty much answered it, but you went for bladder cancer operation anyway, you're going to worry about the spread of the cancer, and again, you're going to have a discussion with the patient as well. In this one, I didn't ask you this question as well, but for the prophylaxis, I think you can make the answer a little better. So usually prophylaxis is not recommended for patients undergoing dental procedures and also for some of the non-dental procedure, but any potentially contaminated surgery, you should consider giving antibiotic for your patients. But generally, it's not recommended for those who are going dental procedures or going non-dental procedures such as upper GI, lower GI, but any kind of operation that could potentially be a contaminated operation or lead to any kind of contamination, you would consider giving prophylactic antibiotic before the operation. Therefore, in the bladder resection, that can potentially be a contaminated operation from the urine, so you would consider giving the patient prophylaxis antibiotic. Side effects of thiazide, you've answered it very well. The thiazide, again, you were fixated on the pathology side of, or sort of explaining more in pathology about how we use thiazide rather than what are the actual pathologies or the actual disease that we use thiazide for. So thiazide is usually used for hypertension patient. It's in the guidelines, chronic heart failure, and diabetes insipidus, and also the calcium calculi as well, right? The patient has some sort of calcium calculi, or actually can lead to calcium calculi. So this is what thiazide is used for, rather than, I think you went through the pathology more than the disease that it's used for. So I think overall, it's a good performance. I think you would still pass, to be honest, but there are a few questions that need a bit of improvement. Okay.
It's very different. It's different from the pathology stem, isn't it? Slightly different. And it's got elements of, for example, heart rate one also comes up in the perforated viscous and AF. But there are also infective endocarditis is also from pathology as well. But there's a lot of overlap, isn't there, between...
Correct. I mean, but after all, at least there are 5 questions that are repeated from aortic stenosis pathology.
Yes.
And that includes the pathophysiology, the clinical picture, and how you calculate the heart rate and the complication of aortic stenosis and the investigations, etc. But again, here you need to think out loud rather than giving answers, and using the method of trying to acknowledge the issue before giving an answer is very important. Right?
Yes.
Even if you acknowledge the issue and then you miss one point in the answer, I think it'll be okay. As long as you acknowledge the main issue, you have some sort of situational awareness of what's going on.
Thank you.
No worries. Let's do pancreatitis. All right. So it's a relatively long scenario. It's not necessarily that all the questions will come in the exam. I think have added so many other questions. I'm not sure if they come in the exam before or not, but we're going to go through them anyway. You have a 45 male patient diagnosed and managed as acute pancreatitis 2 weeks ago. And now the patient presented with tachycardia and shortness of breath. What's your differential diagnosis?
So my differential diagnosis here would be acute pancreatitis, acute cholecystitis causing gallstone pancreatitis, ascending cholangitis, either a pancreatic collection, such as a free fluid in the pancreas, so pseudocyst, or pancreatic necrosis.
All right. What other patient has tachypnea?
So the patient has a tachypnea because pancreatitis can cause acute respiratory distress syndrome. There might be a secondary cause, such as abdominal pain. Patient might be septic due to acute cholecystitis causing gallstone pancreatitis, and or also the pressure from the capsular structure of the pseudocyst.
What are the main functions of the pancreas?
So the main functions of the pancreas can be split up into endocrine and exocrine. The endocrine functions could be from the islet of Langerhans. So the alpha cells secrete glucagon, the beta cells secrete insulin, the delta cells secrete somatostatin, and the exocrine functions are mainly for digestion. So lipase can be secreted for fat digestion, protease to break down proteins into trypsinogen, and to aid stomach digestion as well.
Which factors stimulate pancreas secretion or pancreatic secretion?
So the factors that stimulate pancreatic secretion would be a low bicarbonate. So that would help increase bicarbonate formation for neutralization purposes in the stomach. Low blood glucose would stimulate the secretion of insulin from the beta cells, and high glucose would stimulate glucagon from the alpha cells.
What's the definition of acute pancreatitis?
So the clinical definition of acute pancreatitis is sudden abdominal pain with urinary features or increase in pancreatic enzymes secondary to pancreatic inflammation. And the pathological cause definition would be reversible inflammation of the pancreas associated with a capsular or parenchymal injury.
What are the causes of acute pancreatitis?
So the causes of acute pancreatitis, the main predominant one is gallstone pancreatitis. Other factors would be alcohol, idiopathic, drugs including thiazide, diuretics, and other less common causes would be things such as an ERCP, scorpion venom, and high circulating free fatty acids or hyperlipidemia.
Right. So in this patient, what investigations are you going to offer?
So the investigations I would like to offer there would be bloods, including a full blood count, USANEs, LFTs, renal function, CRP. Want to do a group and save and coagulation if the patient was to go to theatre, and also amylase and a bone profile. Typically, amylase is raised in acute pancreatitis. I'd want to do an ABG to determine whether or not it would be patient is metabolic acidosis or respiratory acidosis. I'd like to organise some non-invasive imaging, such as a plain abdominal X-ray. Want to also do an ultrasound scan to rule out gallstone pancreatitis, and consider doing a CT thorax, abdomen, and pelvis to rule out pseudocyst or evidence of pancreatic necrosis. And then the specific things I'd like to do according to acute pancreatitis would be a lipid profile, calcium, and also to rule out any autoimmune disorders. So I'd like to do an autoimmune screen.
What are the causes of increased amylase level?
The causes of acute amylase level would be chronic pancreatitis, acute pancreatitis, pancreatic necrosis, pancreatic pseudocyst, post-procedure for an ERCP, and any pancreatic surgery.
What can cause normal amylase level in pancreatitis?
So the normal amylase level occurs because typically it returns to normal levels after the acute phase, which is 48 hours. It doesn't correlate with the severity of pancreatitis. However, it does remain in the circulation at low levels, so it doesn't reach zero.
What are the CT findings in it?
The CT findings in acute pancreatitis would be evidence of a pseudocyst. So typically you can get homogeneous, well-defined, rounded pseudocyst. Other things would be evidence of pancreatic inflammation. So sometimes you can see fluid surrounding the pancreas, and sometimes you can get pancreatic calcification, which would be white on a contrast CT scan.
Right, there's a CT scan here for you. Can you comment about the main findings here? I think the answer there, but...
So this is a CT scan on an unidentified individual at unknown time. It's taken at the level of L1 as the L1 vertebra is present. The most abnormal finding here is that you have a pancreatic pseudocyst, which is homogeneous in nature. It's walled off, and there is obviously inflammation of the pancreas as well, with evidence of pancreatic calcification seen by the white on the CT scan. The kidneys look normal as well.
What scoring system is used in acute pancreatitis?
So the scoring system for acute pancreatitis is the Glasgow Emery scoring system. This is based on this is normally done on admission for patients. It's based on PaO2. It's based on calcium level, eGFR for the patient, albumin, and glucose. A score of over 3 is associated with severe pancreatitis. You also have the Ranson criteria, which is done at the time of admission, and also 48 hours after admission. This is based upon the hematocrit, fluid, calcium, PaO2, blood urea nitrate, and the base deficit. And this is the prognostic score for pancreatitis. So a score of 7 or to 11 is essentially 100% mortality.
What's the pathophysiology of hypocalcemia in acute pancreatitis?
So hypocalcemia in acute pancreatitis is split up into an early and a latent phase. The early phase is due to the chelation with free fatty acids. So you get a hypocalcemia causing essentially transient hypoparathyroidism, which would be secondary hypoparathyroidism. And then you also get the latent phase, which is essentially a septic picture, where we get the shift of calcium intracellularly from intracellular to extracellular, causing hypocalcemia.
Patients could get hyperglycemia as well. What's the pathophysiology for that?
This is because the pancreas becomes inflamed, and this causes reduced function in the beta cells and the islet of Langerhans, causing reduced insulin secretion and therefore causing refractory hyperglycemia.
What are the complications of acute pancreatitis?
So the systemic complications for acute pancreatitis would be acute respiratory distress syndrome, pleural effusion and sepsis. And the local complications would be necrosis, pancreatic pseudocyst, abscess, and fluid collection surrounding the pancreas.
How would you define a pseudocyst?
A pseudocyst is an amylase-rich fluid, which is essentially homogeneous and a fibrous wall surrounding granulation tissue. Typically occurs 4 weeks from an acute attack of pancreatitis.
Where is
it? Is usually located in the lesser peritoneal sac. Yep. And the symptoms would be patient presents with localized abdominal pain, nausea and vomiting. The complications are infections such as sepsis. It can lead to rupture because it's a well-defined homogeneous structure, and it can also go into surrounding vessels. And the management is conservative, so I think a large proportion of them resolve within 1 week.
Fine. And how would you manage a pseudocyst?
So the management of a pseudocyst would be to reassure the patient, give them adequate analgesia, and tell them that 40% resolve within 1 week. If a pseudocyst continues to be persistently causing patient pain or evidence of infection, you could do either open drainage or you can do radiologically guided drainage. And this is after a prolonged period of time or responsive to non-conservative measures.
How would you do an open drainage?
Well, typically it's done closed drainage, but open drainage would involve if the patient was extremely septic. So it would be a laparotomy.
Yeah, sorry, I didn't get that. How would you do an open drainage again?
So open drainage would be done via laparotomy or laparoscopically.
Where are you going to drain? Does that make sense?
So here I'd want to drain. I'm assuming that the pseudocyst would have ruptured, so I would like to drain the lesser sac.
I'm not sure if you understand my question correctly, but let me paraphrase it. So you have a patient with a pseudocyst. It hasn't ruptured, and you would like to do an open drainage because after you've done a radiologically guided drainage, the pseudocyst refilled. So how are you going to have a sustainable treatment for a pseudocyst?
So here I would do repetitive drainage.
Is this a sustainable treatment?
No, it's not a sustainable treatment. So here you could do a laparotomy and do a washout of the abdomen, including the pancreas. Okay. But I'm not too certain, so could I move on to the next question, please?
That's fine. What's the role of corticosteroids in acute pancreatitis?
So the role of corticosteroids in acute pancreatitis is that it reduces the inflammation of the pancreas and has a role in decreasing mortality and morbidity and reduces length of hospital stay.
The patient complicated with a splenic vein thrombosis, how are you going to treat that?
So a splenic vein thrombosis can be treated depending on whether or not the patient is hemodynamically stable or unstable. If the patient is hemodynamically stable, we can give low molecular weight heparin, such as tinzaparin. If the patient is unstable, you could either do a thrombolectomy or embolectomy. This can be done. I'd also want to have imaging for the patient before, so I'd like to do a CT angiogram for the location of the thrombosis and MDT discussion with the vascular team and radiology as well.
And how does paracetamol overdose cause liver injury?
So the paracetamol overdose causes liver injury by affecting the liver enzymes. I think it typically affects the glucuronidase transferase enzyme and causes deranged LFTs. It's treated by giving NAC, which is N-acetylcysteine.
Fine. I think overall, very good performance. As I said, this is a very long scenario. There are multiple questions I've added, not necessarily that they come in the exam, but they are relevant to acute pancreatitis. I think first and second question were answered very good. Third question again was very well. Factor that stimulate pancreatic secretion. I think you need to be a little bit more specific here by mentioning things like cholecystokinin, the vagal stimulation, the secretine, the gastrin. I think you went into sort of a feedback mechanism by low glucose can lead to that, and low, I think you said something else, I don't remember. But basically, you want to mention into the specific enzymes or hormones that can increase the secretion of the pancreas. Vagal stimulation, or splanchnic nerve, secretine, and cholecystokinin, and the gastrin as well, right? Of course, low glucose can stimulate production of insulin, but it's still the main things are correct. Definition of acute pancreatitis, I think you've given a good answer, but I think you need to polish this a little bit. So you need to make it quick and slick. I think it's slicker than this. I like that you classify into clinical and pathological. The clinical is just explaining what actually happened. Sudden severe central abdominal pain with increased urine and blood pancreatic enzyme due to pancreatic inflammation. As simple as that. And pathological, it's reversible pancreatic inflammation or injury. Causes, I think you need to focus on gallstones and alcohol. And those are the two main causes of acute pancreatitis. And then you can mention the other. So almost 90% of the cause will be gallstones and alcohol, and the rest will be just 10%. So we just want to highlight the beginning, the gallstones and the alcohol, and then you can mention anything else. Yep. Investigations, I think you classified investigations very well, and there's nothing to add really in investigations. The commonest finding in a CT scan is actually normal CT scan. So you wouldn't really get any finding on a CT scan in acute pancreatitis, and that's why the decision to do a CT scan in acute pancreatitis is usually not done in the first 3 days. You wouldn't expose your patient to radiation, and you're trying to reserve that CT scan if you're worried about something like a pseudocyst or you're worried about necrosis, all right? And that will be after you've done all the investigations and you couldn't find anything else. But actually the first imaging that you will offer for acute pancreatitis patient, do you know what's the first imaging that you're going to offer for acute pancreatitis patient?
It's not an ultrasound scan, is it?
It is actually an ultrasound. And why are you doing an ultrasound?
Because the most common cause is gallstone pancreatitis.
Yeah, you're doing an ultrasound to look at the gallbladder rather than looking at the pancreas, all right? You're just to find out if there is any stone or not. This question, you've answered it very well, so no problem with that. So the CT finding, the commonest one is actually normal, but you can get some edema, fat stranding around the pancreas, collection, necrosis, abscess, and later on a pseudocyst. All right, but the commonest finding is actually a normal CT scan. I think this question you've answered it very well. You picked on the I know the answer is there, but you've presented it very well. The pseudocyst and the calcification in the pancreas. The scoring system, again, you've mentioned it very well.
Do we mention I think there's a radiological scoring system as well, but do we just mention the Glasgow IMRI?
I don't think that you need to mention the radiological one. You mainly need to mention the Glasgow IMRI and Ransom criteria, and I don't think that you need to go through the specifics of it. I think they're just asking for the names of the scoring system, what are the importance of this, and you've clearly mentioned that one is for prognosis or prognostication of your patient, and they are both done on sort of admission within 48 hours. This is exactly what's needed when you answer this question. Hyperglycemia, you've answered it well. The complications, again, you've given a very good answer, but I would focus on those four because for some reason they like it. So the acute peripancreatic collection, this is an acute phase that can turn into a pseudocyst. An acute necrotic collection, again, this is an acute phase that can turn into a world of necrosis. Those four are very important to mention, but you can also mention all the other complications, CVS and respiratory and shock and ARDS and abscess, etc. You can also classify your complications into systemic complications, right? The local are the four that we just mentioned, and the systemic could be on all the other systems, all right? A pseudocyst definition, that was good. Location, that was good. And until you, for management of pseudocyst, I was trying to get you to say that you're going to do a cystostomy, basically. So the way you drain it, if you're doing an open procedure, which is actually very rare, it doesn't really happen very often unless everything has failed. You do a laparoscopy, but you're going to open the cyst into the stomach. All right. So that will be a more sustainable solution, but it doesn't usually happen very often. I didn't ask you the management of acute pancreatitis because we sort of focus on everything. We talked about investigation, we talked about your initial management and supportive treatment, and we touched base on the ERCP and before, I guess. Antibiotic, would you give antibiotic for those patients?
Not routinely, no.
And we talked about the role of surgery. You will only do surgery if there is significant necrosis and you want to do resection, or if there is a pseudocyst.
Yes.
Corticosteroids, I think you mentioned the role. Treatment of vein thrombosis, again, you mentioned the role. The paracetamol. So you want to mention here the NAPK, right? So the toxic metabolites called NAPK, which is neutralized by glutathione. And excess paracetamol usually is not all NAPK, but is also neutralized, accumulating in the liver and can lead to basically affecting all the functions. But you want to mention the NAPK, and also you touch a bit on treatment, which is good as well. I think at some point, I don't remember which question was it, but you mentioned that pseudocyst could happen in acute phase, but actually pseudocyst in a very chronic phase.
Yes.
I don't remember which question was it, but it was one of the questions that you mentioned pseudocyst in your answer. But pseudocyst happens very chronic phase, so the patient can come 4 to 6 weeks later with the symptoms, right? So it doesn't happen in the acute phase, right? I think overall that's good performance, and like I said, not all the questions will come in the exam. Some of them will, but not all of them.
Thank you.
All right, let's start by osteoporosis. I know you haven't asked for this, but it's sort of relevant because I think those three scenarios are sort of related: osteoporosis, steroids, and then Addison's disease. So let's actually start by steroids, and then we can move on to osteoporosis. Right, you have a rheumatoid arthritis patient who was on steroids and some immunomodulators as well. What are the layers of adrenal gland?
So you have the zone of glomerulus, which secretes aldosterone. You have the zone of fasciculata, which secretes cortisol, and have the zona reticularis, which causes androgen or sex hormone secretion.
Yeah. And also you want to mention the medulla as well. So the cortex, which what you mentioned, and the medulla, which secretes.
So the adrenal medulla, I should know this. It's catecholamine, that's right.
What are the actions of aldosterone or mineralocorticoid?
Aldosterone, the main actions are number one, it's for sodium balance. So it causes the reabsorption of sodium, typically in the distal convoluted tubule and the collecting duct. And subsequently, because of that, we have also monitoring water balance or homeostasis. So with sodium, water follows. So increase in serum sodium causes also intracellular movement of water as well. And this is typically done by ADH. You also have the maintenance of potassium, so it causes loss of potassium, which can cause metabolic alkalosis.
What are the actions of cortisol?
So the actions of cortisol are carbohydrate metabolism. So it allows breakdown of carbohydrates, causing hyperglycemia. It also causes the stimulation of amino acid uptake, and also can cause the action of lipase. So it causes fats to be broken down. So it's mainly catabolic. Then you have the mineralocorticoid action of cortisol, which causes the stimulation or secretion of sodium and water excretion. Other things are it's increased in stress. So it's a stress hormone. And this is typically done by the HPA axis.
And what advice would you give to your patient who is starting steroids?
So the advice for patients would be do not stop the steroids acutely. If the patient becomes unwell, then we might need to double the dose of steroids. If there's any evidence of infection, we might need to double dose the steroids. And the patient should also notify their doctors on admission, and also can carry a steroid card to let them know that they're on steroids.
Very good. So before we move on, I'm just going to give feedback here quickly, and then we can move on to the next question. So I think here everybody focus on the cortex, and we forgot the medulla. All right. So medulla is still an important part to mention in the adrenal gland. The action of aldosterone, I think you could have made it a little bit shorter. So it works in three things: salt and water retention. Just make it simple: salt and water retention, potassium balance and acid-base balance, because it's relating to the hydrogen and potassium exchange, right? So salt and water retention, it will lead to retention of sodium, because it leads to sodium reabsorption from distal convoluted tubule, sweat glands, salivary glands, and your gut, and basically everywhere. Water balance, again, increasing the serum sodium inside the tubules will attract more water, right? So it will lead to salt and water retention. This is what it means. Potassium balance, again, it works on the potassium and the hydrogen. It will, exactly, so you can lose some potassium, and also the hydrogen maybe exchange with the sodium as well. So basically you can get metabolic alkalosis or paradoxical aciduria due to more hydrogen in the urine. All right.
And that's via the activation of RAS, isn't it? And hypovolemia. Yeah.
Correct. So RAS will be activated. So I was actually talking to someone about this. So what are the actions of the RAS system, the final actions?
So the final actions of the RAS system would be 1, aldosterone secretion. Number 2 would be the retention of sodium. Number 3 would be activation of ADH. So you'd increase via V1 and V2 receptor. So you'd get vasoconstriction of the arterioles. That's typically led by angiotensin 2. And then also you get activation of V2 receptors. So you get increase in aquaporin channels, transmembrane channels in the distal convoluted tubular and collecting duct predominantly, causing the reabsorption of water and sodium. And all these 4 mechanisms of RAS, or the endpoints of RAS, would increase your systemic vascular resistance and therefore increase your cardiac output.
I think there is a bit of mix-up in the answer that you've given, right? So you've mentioned the good terms that needs to be mentioned, but I think they're a little bit mixed up. So I think the function of the RAS system are 3 things. And it will make much more sense when you explain it in this way. So basically, you have a patient who is currently in hypovolemia, whether they are bleeding or they are in dehydration or whatever the reason is, sepsis or whatever. So the RAS system will be activated, and it will end up in 2 things, all right? Leading to production of your angiotensin 2 and production of aldosterone, all right? So the angiotensin 2 will do 3 functions. Increase production of aldosterone, and this will lead to these functions, what we just mentioned, right? So salt and water retention. So now you have more fluid into intravascular fluid. So you increase the intravascular volume to increase your venous return, to increase your cardiac output. So it works sequentially, as I mentioned, right? And then you will cause vasoconstriction to 2 things. Vasoconstriction to the veins, that will increase your venous return, and vasoconstriction to the arterioles, and that will increase your peripheral vascular resistance. All right. So increasing the venous return, what will increase the cardiac output?
Well, that's due to Frank-Starling relationship.
Correct. So that will increase your cardiac output. Increasing the peripheral vascular resistance, what will increase your blood pressure. So it doesn't necessarily increase your cardiac output.
No.
So to summarize, 3 things: vasoconstriction to veins, vasoconstriction to arterioles, increase in production of aldosterone. These are the 3 main functions. All right. The actions: metabolic and mineralocorticoid, and other actions. Metabolic can be work on carbs, protein, and fats as well. All right. So lipolysis and the amino acid uptake, and the hyperglycemic effect of the carbohydrate, anti-inflammatory, etc. Precautions. You've mentioned this very well. It was a good answer. And to know the side effects, that's another thing to mention.
Yes.
All right. The osteoporosis. What are the side effects of steroids? How would you explain it?
So the side effects of steroids, I think you split it up, but I can't remember. Is it local and systemic effects?
Yes.
Or you go from out to in, or you can split it common and uncommon. So the local effects would be delayed wound healing, infection, osteoporosis, which is where you have an increased risk in fractures due to decreased bone mineralization. You could also have weight gain. So the systemic effects would be weight gain, hyperglycemia. It can also cause muscle weakness and atrophy, and also can cause behavioral changes.
That's right. That's good. There are multiple ways that you can classify it. The way that I prefer is actually going from out in, so skin, muscle, bone, blood vessels, hormones, and the redistribution of fat. These are the main things. All right, that's fine. I think that's it for this scenario. The same patient presented to you later on with a neck femur fracture. All right. This scenario can also be linked up with the giant cell arthritis patient who was started on steroids, and then we can move and say, your patient now coming to you with a nickel femur fracture.
Yes.
What's the most likely cause or predisposing factor here?
The most likely cause is that the patient is on long-term steroids, and also the patient is female and elderly. So she is postmenopausal.
Why long-term steroids can lead to nickel femur fracture?
So long-term steroids cause nickel femur fracture because they can cause osteoporosis, and this is because they cause decreased bone mineral density.
And it can also cause avascular necrosis of the nickel femur.
The femoral head.
What are the pathological changes in osteoporosis?
The pathological changes in osteoporosis is that you would have a normal bone quality, so normal calcification of the bone, but you have a reduced bone mineral density. So you lose essentially a trabeculae of the bone.
And how would you define osteoporosis?
So I define osteoporosis as a reduced bone mineral density, but normal bone quality.
How does corticosteroid cause osteoporosis? I think we sort of mentioned that. What are the causes of osteoporosis?
The causes of osteoporosis can be postmenopausal females due to lack of estrogen. You can also have patients that are high BMI, patients that have on long-term steroids, previous radiotherapy and chemotherapy, a family history of osteoporosis as well, and the patients that have had multiple previous fractures.
What are the other causes of pathological fracture?
The other causes of pathological fracture could be radiotherapy, chemotherapy, metastasis from a secondary tumor, and also trauma.
Trauma is not necessarily a pathological fracture, but you can radiotherapy, Paget disease, multiple myeloma, rickets, osteomalacia, etc. But trauma is sort of not a pathological fracture, it's a traumatic fracture. Yeah. If you're taking this patient to surgery, what's your main concerns preoperatively?
So the main concern preoperatively is that we would have to stop the steroids acutely. This might cause the patient to go into Addison crisis, as there'd be a reduction in circulating steroids.
Why would you stop steroids in this patient?
No, as in the patient might not be counselled and stop their steroids acutely, but here we would have to bridge or reduce or give double the dose of steroids. So the patient would need to be counselled on or have a preoperative workup for them going to surgery. All
right, so I would kindly ask you to rephrase your answer. So what are you going to do for this patient preoperatively in terms of steroid management?
So preoperatively, I would want to double the dose of steroid for the patient according to certain guidelines that I'm uncertain of. I'd want to ensure that the patient has had a medical review and an anaesthetic review as well. The Addison's crisis, though.
Correct. And how would you prevent it? You will double the dose, as we mentioned.
Yes.
Okay. All right. The patient underwent total hip replacement and died post-operative day one. What's your commonest cause for death post-operative?
So the commonest cause for death would be a pulmonary embolism or Addison's crisis.
Addison's crisis could be a reason, but you're right. Talking about pulmonary embolism is more important, especially fat embolism would be the most important one to mention. Right. So fat embolism. I think the cause of osteoporosis, there is an area of improvement. You can classify primary and secondary, and you can mention multiple secondary causes, endocrinological and gastrointestinal and medications such as steroids, anticoagulant, antiepileptic, specifically levetiracetam. So I always focus on this because I worked in orthopedics for a year before I started my neurosurgery. And when I worked in orthopedic for a full year, I've noticed that we have lots of neurosurgical patients who are either on a steroid or Cupra, all right? And they end up having nickel femur fracture. So that's what I mean. Now I'm pretty self-conscious about this. When you put your patient on steroids, you need to put a stop date from day one, because otherwise you will end up in an orthopedic ward with nickel femur fracture. They're very old and frail. When you put your patient on Cupra, you need to be aware of that risk and also mention that, because the Cupra can cause thickening of the cortex of the bone, and that will basically increase the stress point of the bone and then can lead to fracture. So I know you're in orthopedics, you will notice this quite a lot if you work in a tertiary center. Lots of neurosurgical patients will end up with nickel femur fracture for that reason. All right, that's fine. So like I said, steroids can be linked to osteoporosis, can be linked to Addisonian crisis, which we're going to talk about now. What's your definition of Addisonian crisis?
So, Addisonian crisis can be defined as a reduction in the circulating steroids. The primary Addison's is due to Addison's disease. So, this is due to a lack of adrenal cortisol secretion not meeting the body's requirements. And the secondary can be due to trauma, surgery, or infection. But most commonly, it's associated with stopping steroids acutely.
What are the clinical features of this crisis?
The clinical features would be abdominal pain, nausea and vomiting, unexplained shock, and also the blood picture would be hypokalemia and hyponatremia and metabolic alkalosis.
And how do you prevent it?
So we prevent Addison's by counselling the patient to not stop their steroids acutely, carry a steroid card with them and notify doctors that they're on long-term steroids. And if they're unwell, duplicate or double the dose. And preoperatively, the patient's steroids would be doubled if they're going to surgery, and oral will be converted to IV steroids.
And what's the management of this crisis?
So I would like to manage this patient according to CRISP protocol. I'd want to do a full history and examination, including a review of the drug chart. I would like to start the patient on IV hydrocortisone, which is 100 milligram bolus, and then titrate accordingly, giving them a IV hydrocortisone continuously over 24 hours. They'll require typically aggressive rehydration, so I'd like to give some IV fluids, either 4 to 6 litres over 24 hours. And then I'd also like to have an MDT discussion involving the surgeon, ITU, and endocrinologist as well.
All right, well done. So I think overall good performance in the steroid side of things. Osteoporosis needs a bit of improvement. I do understand that you might haven't gone through it, which is understandable. But I think the steroids and the Addisonian crisis is very well done. All right, let's do one more. I'll let you choose one more from those four.
Shall we do post-operative oliguria?
All right. So you have a 48-year-old female patient, persistently hypotensive following a total hip replacement or a Hartmann procedure. Sometimes it comes as Hartmann procedure. She was transferred to the ward at 3 p.m. She was hypotensive, tachycardic, with a blood pressure of 70/30. And you will be given a fluid chart as well that will show you how much fluid the patient was given. And this patient was given 2 bolus of 250 ml over 15 minutes with a very small improvement initially. You will be asked to interpret the fluid chart. So what are we actually looking at when you're trying to interpret it?
So on this fluid chart, I can see that the patient is had 2 fluid challenges and nothing in between. They've had a small improvement, however, are still hypotensive and tachycardic. My main concern here is that the patient has post-operative oliguria.
And is the amount of fluid given adequate?
No, the amount of fluid here is not adequate.
And how would you manage this case?
So given the fact that the patient has had previous fluid challenges, they've had 2 previous fluid challenges, I'd like to manage this patient according to CRISP protocol. I want to do a full history and examination of the patient and review the drug chart that I've been given and medication chart. I would like to give a additional fluid challenge and monitor the response. I'd give a 250 ml bolus over 15 minutes. I'd want to identify, this would be diagnostic. I'd want to identify if this is hypovolemic. If they have response to this, then I would start fluid resuscitation. And if there was no improvement, I'd like to repeat the fluid challenge up to 4 times, which would equate to 1 litre.
What formula do you use for fluid challenge?
So the formula used for fluid challenge is 20 milligram per kg over 30 minutes.
The patient is on 2-hour monitoring. Is that adequate?
No, the patient should be managed hourly.
And who would you notify and when?
So I would notify my consultant on call and the ITU consultant as well. I would notify them if the patient was unresponsive to the 4 fluid challenges, as I can give up to 4 according to NICE guidelines. This is important as the patient would need to be monitored either with a pulmonary arterial catheter to monitor their cardiac output, and this typically can be done in an ITU setting.
And how would you calculate the blood pressure?
So blood pressure is calculated, blood pressure equates to cardiac output times heart rate, and cardiac output is calculated with heart rate times systemic stroke volume, So blood pressure is calculated cardiac output times systemic vascular resistance, and cardiac output is calculated by heart rate times stroke volume.
According to this equation, how would you increase the blood pressure?
So cardiac output can be increased by inotropic support and giving IV fluids, and vasopressor agents can increase systemic vascular resistance.
Right. What is the hormonal response to surgery?
So the hormonal response to surgery is based upon a stress response. So because of this, we have increase in cortisol secretion. This is from the zona fasciculata in the adrenal gland. We also have increase in adrenaline and noradrenaline, and we'd have a increase in cytokine secretion. We'd have a decrease in thyroid hormone stimulation, so decrease in TSH and T3 and T4.
What are the mechanisms by which the kidneys increase the osmolarity and the renal medulla?
So this is by the theory of the countercurrent multiplier. So here you have the countercurrent multiplier, which is based upon medullary hypertonicity. We have reabsorption of sodium chloride in the thick ascending loop of Henle. This is because it's impermeable to water, but permeable to sodium chloride. And therefore you have a inflow of sodium chloride into the PCT and ascending loop of Henle. You have fluid leaving the PCT, which is isotonic, and you have an efflux of sodium chloride from the ascending loop of Henle. And also because of the vasa recta, you have a flux of water from the collecting duct tubules.
What's the mechanism of the ADH?
So the mechanism of action of ADH is based upon the V1 and V2 receptor. The V1 receptor would cause vasoconstriction and therefore increase the risk for vascular resistance. And the V2 receptor is for water reabsorption in the renal, predominantly the collecting duct and also the distal convoluted tubule by the increased secretion of aquaporin 2. It's stored in the hypothalamus and secreted from the posterior pituitary gland in response to hypovolemia.
All right. We talked about RAS in the previous lecture. It's the same thing here, basically. So it leads to vasoconstriction to veins, arterioles, and salt and water retention by ADH and aldosterone. Not sure if there's anything to mention here. Corrected yourself in the blood pressure. I think I need to rephrase the question because that doesn't make sense, to be honest.
The equation?
It's asking about the blood pressure equation and the significance of that. Hormonal response, cortisol, adrenaline, and cytokines. And just mention that this is the stress response. Surgery is stress, which you did. This is obviously, I might need to rewrite this in a better way, but you've made a good summary of it. I think that's it. There's nothing really to add. For interpreting your flow chart, I think the key points to mention that you're looking at in the flow chart, first of all, you're looking at the patient blood pressure and the intake and the output. So the output is very important.
Because it's if they're in a negative balance or positive balance.
Correct. So the output needs to be mentioned as well, right? So what's the urinary output, whether it's being calculated or not, whether the patient have a urinary catheter, and all these questions.
Okay. Sometimes I think in the STEM they ask about cardiac output and how that's measured. So lithium dilution, cardiac output monitoring, and pulse control analysis, and central line and transesophageal Doppler, I think. But those are just specifics, aren't they? We had this STEM in teaching today. There's some stuff that I'd obviously not read about, but had to read up about.
I wasn't aware of that, but can be added as well. I think overall, well done.